Countdown after start, sir.
Okay, your voice is echoing.
सर मेरा तो मेरे एक ही सिस्टम से ज्वाइन किया है। आपने सर
अच्छा।
दो सिस्टम से शायद ज्वाइन किया है, या फिर आपके नियर बाय कोई दूसरा सिस्टम ऑन है। सर कैन वी स्टार्ट?
Yes,
ओके सर।
we can start.
ओके सर, प्लीज स्टार्ट इन 3, 2, 1। प्लीज स्टार्ट सर, वी आर लाइव।
Okay. Very good evening to all the HCBs who has joined now, to the medical fraternity those who have joined now, and very warm welcome to our Anupam sir. So yes, so Anupam sir is a renowned clinical oncologist in Health City Hospital. He is a consultant oncologist there, and today he'll be delivering lecture on advancing MHSPC treatment horizons, darolutamide without chemotherapy, and not evidence with error. So, sir, with this, can you start now?
Yes, good evening, Bear, and other esteemed panelists and doctors. So, can you share the slide on my behalf?
Okay, sir, let me check it out. Sir, I am sharing now. Okay.
Yeah.
Sir, can we start now?
Yes, we can start. So, good evening. So, next slide, please. Next slide. So, we all know that the standard of care in metastatic hormone-sensitive prostate cancer has evolved to combine ADT with AR inhibitors, abiraterone, or docetaxel. And this begins from 2014, where SARTED trial were used docetaxel and ADT, and in 2015, STAMPED, where docetaxel with ADT was used. In 2017, the Latitude trial where abiraterone was used along with the ADT, and in the STAMPED ARMSy where abiraterone ADT in 2018, and in 2019, ARCES where enzalutamide used along with the ADT, and in 2021, in 2019 also, we have Titan, apolatamide where came into the market, ADT, and Enzamet where enzalutamide, ADT with or without docetaxel were used, and in 2022, Arasens where darolutamide were used along with ADT and docetaxel, and in 2024, lastly, that is your Aranot and Arasec trial where darolutamide were used along with ADT without docetaxel. So despite treatment with ARPI and ADT or docetaxel and ADT, a large proportion of patients with metastatic hormone-sensitive prostate cancer will progress to mCRPC within around 3 years. Next slide. So there is an unmet therapeutic need, which remains an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicity and with a low drug-drug interaction potential. ERASEN is a phase 3 study in combination with docetaxel, already showed beneficiary efficacy and safety profile, leading to its approval in India in 2023. And the darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic sensitive prostate cancer patients, as demonstrated in the global phase 3 study ERANODE trial with significant Indian patients. With the ERANODE data, darolutamide has the potential to change the treatment paradigm, and now it would be only ARI which could be used then without chemotherapy. Next slide, please. So this is the background. Darolutamide with ADT with docetaxel is a standard of care for metastatic hormone-sensitive prostate cancer. And in ERASENS, this combination demonstrated favorable efficacy and safety versus ADT and docetaxel. And in ERANODE was designed to evaluate the combination of darolutamide with ADT versus ADT to provide a new treatment option for this group of patients without docetaxel. Next slide. So here you can see the ERANODE study design. It is a randomized double-blinded placebo-controlled phase 3 study, and the patients were metastatic hormone-sensitive prostate cancer, histologically or cytologically confirmed adenocarcinoma of the prostate, ECOG PS between 0 and 2, and stratification factors were visceral metastasis assessed by the central review whether they are present or absent. And they were randomized in a 2:1 ratio to receive darolutamide 600 milligram twice daily along with ADT, and in the other arm, placebo and ADT were used. And the primary endpoints were radiographic progression-free survival, and the secondary endpoints, OS is a key secondary endpoint, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, and rates of undetectable PSA, that is less than 0.2 nanogram per ml, and time to pain progression using SPI, SF, and the safety. And other pre-specified endpoints, PFS2, time to SSC, time to deterioration of patient's health, and this is median cut of June 7, 2024, and median follow-up approximately 25 months in the both darolutamide and placebo group. Next slide. And this is the patient demographic and clinical characteristics at baseline. You can see in the almost 30 patients were Asian, and the metastasis initial presentation, almost 70% has de novo metastasis, and disease volume were in high in almost 70% of both group. And the prior therapy, almost 18% has received prior therapy, and the visceral metastasis seen around 11%. Next slide. So this is the country represented across breakthrough clinical trials for prostate cancer treatment in different areas. ERANODE trial, AMBER trial. ERANODE trial includes Asia, 30% patients, Latin America, 29%, Europe and rest of the world, 41%. Next slide. So this is the APC regional presenter. Among this, India and China represent of the majority of the patients, 14 and 13% in the darolutamide group, and the placebo 11 and 14%. And then Australia 4%, New Zealand 2.2%. Next slide. And the combination of darolutamide and ADT significantly reduced the risk of radiological progression of rate by 46% versus placebo with ADT. So it's a hazard ratio of 0.54. In the Deluta arm, it is not traceable, while in the placebo, median was 25 months. So median follow-up around 25 months in the both group. Next slide. So the benefit of, this is the forest plot, you can see, the benefit of darolutamide and ADT on radiographic PFS was consistent across the subgroups, including patients with high and low volume disease. Here you can see in all cases, whether ECOG PS 0 or more than 1, baseline PSA, high or low, disease volume, high volume, low volume, and in all races, and whether visceral metastasis is present or absent, and with prior local therapy in all subgroup analysis that favors darolutamide with ADT. Next slide. So coming to the disease volume. So it is all secondary endpoints benefit OS. Next slide. This is the subgroup analysis of radiographic PFS. In the next slide, you can see other secondary endpoints: OS, time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy for prostate cancer, time to pain progression. All demonstrated benefit across these subgroups, favoring darolutamide. At the time of primary analysis, OS data are immature. Since OS immature, patients will be followed for survival, and all remaining per protocol placebo patients offered crossover to darolutamide after primary analysis. Next slide. So this combination delayed time to CRPC and time to pain progression, or time to metastatic CRPC, darolutamide ADT median not is, while placebo, it is 13.8 months with a hazard ratio of 0.4. While time to pain progression for the active arm, median was not disable, and for the placebo arm, it was 29.9 months with a hazard ratio of 0.72. So these delays in time to pain progression can be of high importance to patients and have not demonstrated with any other AR inhibitors to date. Because we know those osteoblastic painful metastases, bone metastases are very painful. So control of pain is one of the important aspects of treating metastatic prostatic bone cancer, prostatic cancer with bone mets. Next slide. This also combination achieved a deep and durable PSA response. PSA of less than 0.2 nanogram per ml at any time during treatment, while in the darolutamide and ADT, it is 62.6%, and while the overall in the combination, it is 18.5%. And time to PSA progression for the active arm was not visible, while the combination of placebo and ADT median was 16.8 months, with a very significant hazard ratio of 0.31. So 63% of patients in the darolutamide doublet arm attained PSA less than 0.2 nanogram per ml, and this represented a 69% improvement in the time to PSA progression in the darolutamide arm versus ADT alone. Next slide. Similarly, a higher proportion of patients achieve undetectable PSA with darolutamide versus placebo in both high volume and low volume subgroups. In high volume subgroups, you can see at 24 weeks, 44 for the darolutamide versus 10 for the placebo. And this is at any time, you can see 54.6% as compared to 15.5% for the placebo for the high volume. And similarly, you can see in the low volume also. This is. Next slide. And the subsequent life-prolonging anti-cancer therapy in the darolutamide and ADT, who discontinued was 45%, that is 203, absolute number, and in the placebo, it is 71.7. So discontinuation rate is much higher in the placebo arm as compared to the darolutamide and ADT. And patient with subsequent Lymphoma systemic therapy, all 32% received darolutamide in the arm, and in the placebo arm, it is 42.5%. So there are more number of patients receiving second line therapy. And the docetaxel was the most commonly used agent, followed by abiraterone, enzalutamide, apalutamide, cabazitaxel, radium, and in the those with BRCA inhibitors, olaparib, the PARP inhibitor. Next slide. Next slide. And the incidence of treatment emergent adverse events were similar between the treatment groups, and discontinuation were lower in the darolutamide arm. In the any adverse event, it is almost similar, 90%. Worse, grade 3 or more, it is similar, 30% for the darolutamide and the placebo arm, and the serious adverse event were around 23% for the both arm. And that leading to permanent discontinuation of darolutamide is 6.1% versus 9% for the placebo. And the median treatment duration was 24 months in the darolutamide arm versus 17 months in the placebo arm. And the safety profile of darolutamide in ARANOTE was independent of PSA response and consistent with the favorable tolerability first in the ARAMIS and ARASENS style. Next slide. And these are the list of most common side effects. These incidents were low in the arm and similar in the both treatment arm. Mostly anemia, arthralgia, UTI, back pain, transaminitis, constant hot flushing, it is, and pain in the extremities, and the fatigue. Fatigue is more commoner with placebo arm. Next slide. And these rates of adverse events commonly associated with androgen receptor ARPS were similar across treatment arm. In the adverse event, in the hypertension is the most common, around 9%, followed by vasodilation and flushing, diabetes mellitus and hypoglycemia, cardiac arrhythmias, fatigue, rash, bone fracture. These are all in the less than 5% or less. Heart failure, it is seen in less than 1%. Cerebral ischemia is the rarest one with 0.2% on. Next slide. So in the ASCO 2025, it has present darolutamide confers a positive impact on health-related quality of life. It extended median time to deterioration in FACT total score by 5.1 months versus placebo. And it is the first and only ARI inhibitor to demonstrate clinically meaningful delays in the pain progression and overall well-being. And the time to deterioration of FACT total score are not specific exploratory endpoint. On the darolutamide and ADT, it was 16.8 months, and as compared to placebo, 11.5 months with a hazard ratio of 0.76. Next slide. So this darolutamide doublet therapy demonstrates clinically meaningful delays in deterioration of overall well-being, especially in social functional urinary symptoms domain. You can see in the social well-being, functional well-being, in the prostate care, bowel symptoms are not much affected, but urinary symptoms are decreased with the darolutamide. This all favors darolutamide over placebo. Next slide. So in conclusion, combination of darolutamide to ADT significantly improve radiographic PFS in patients with metastatic hormone-sensitive prostate cancer, and it showed that the benefit across all secondary endpoints. Darolutamide was associated with a deep PSA response regardless of baseline PSA, and it is the first and only ARI inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social family well-being, functional well-being, and urinary symptoms. And it has a favorable safety profile. So this combination without docetaxel should become an additional standard of care for patients with metastatic hormone-sensitive prostate cancer. So thank you.
Thank you very much, sir, for this insightful and informative presentation on Aeronaut, and looking forward to you in future for such type of educational program. Thank you, sir. And with this, I am moving towards Nair sir is there. So with this, if you can start with Nair sir now. Sir, shall we start? If you are okay with it.
Yeah, I'll share my
Okay.
screen.
Sir, you will be sharing or shall I?
Yeah, I'm sharing.
Okay. So Naresh sir will be presenting on reaching new highlights on MHSPC care.
Yeah, is my screen visible? Am I audible?
Yes, sir, you are visible as well as audible.
Thank you, Padma, for the kind introduction. Good evening, everyone. Good evening, one and all, to all the respected doctors. Thank you, Bayer, for asking me to present this topic here today. At the outset, slides are basically sponsored from Bayer Oncology. So to begin with, we are all aware of the landscape of prostate cancer. So patients initially diagnosed as localized or locally advanced, a large percentage of these patients get cured, but some of them do progress at certain point of time, either in the form of biochemical recurrence or radiological recurrence, to enter a phase of metastatic hormone-sensitive prostate cancer. At that point, ADT becomes the fundamental therapy that all of these patients should receive. And at some point of time, most of these patients do enter the phase of castrate resistance, which is the most difficult phase to treat in the entire paradigm of treatment of prostate cancer. And most of the patients who die because of prostate cancer do have a castrate resistant prostate cancer, and its various treatment outcomes have met with significant challenges, with poor overall survival in the resistant phase. So that is where we get an opportunity in the hormone sensitive phase. If we treat these patients properly, we might be able to delay the castrate resistant phase. And that is why time to castrate resistance has also become an important endpoint in large number of clinical trials. Now, we have come a long way from ADT alone being the standard of care at some point of time in the past. And as we can see from this graph, ADT alone has led to very poorer outcomes as compared to what we get today. In terms of proportion-free survival, it's hardly a year, and the overall survival is somewhere about 14 months. So definitely ADT alone was never enough, and at this point in time, we can do much, much better than this. Stampede trial, if you go through the trial design, it was an extremely complicated trial with large number of arms. A large number of arms were actually stopped prematurely. But one of the many questions that was addressed in the STAMPEDE study was the local of radiotherapy in patients with metastatic hormone-sensitive prostate cancer. And what this study showed that patients with low volume disease, that is less than 4 bony metastasis, adding radiotherapy to the local prostate gland does improve the failure-free survival and overall survival. Whereas high volume disease, there is no role of local radiation. We have added a large number of systemic therapies to the backbone of ADT, and over the past 1 or 2 decades, we have been able to improve the survival outcomes by using various permutations and combinations. And now we look at the therapy either in the form of a doublet or in the form of triplet. So now we have a wealth of data supporting concomitant therapies. Now the challenge is not, what to give, but whom to give what. So let us go through some of the data that we have. So in the CHARTED trial, which explored the role of chemotherapy in hormone-sensitive prostate cancer, what this trial shows us that adding docetaxel does improve the overall survival in patients, but the value of adding chemotherapy is extremely high in patients who have a high volume disease with an impressive hazard ratio of 0.6, leading to an improvement in overall survival of almost 17 months. This effect is not seen in patients with a low volume disease. As we can see, the hazard ratio crosses 1 with an insignificant p-value. So that is one takeaway from the CHARTED trial that we have. Latitude addressed the issue of adding, though again this trial had also a large number of arms, but predominantly it was projected as adding a non-chemotherapy partner to the ADT group. And what it showed that even without chemotherapy, as Anupam sir also discussed in the previous study, that even without chemotherapy, adding some kind of a hormone manipulation to the ADT backbone, it was effective and it improved overall survival. However, one of the biggest criticism of the Latitude trial was that it was an extremely long kind of lasting study during which the standard of care, which was the comparative arm, actually changed. So that is also one of the criticism. Even though adding abiraterone improves outcomes, all of us who have used this drug know that it is plagued with certain toxicities, predominantly related to the mechanism of action and the need of concomitant steroid administration. We have faced toxicities in the form of hypertension, cardiac issues, fluid retention, effects on bones, so on and so forth. And it is more relevant in patients of prostate cancer because most of these patients tend to be elderly with pre-existing cardiopulmonary illnesses. Then we have other amide group molecules which have been added to the ADT backbone. The Titan study with apalutamide showed improvement in PFS and OS across all subgroups, and this showed PFS benefit even in the high volume versus low volume categories. Enzamed addressed the addition of enzalutamide, which is another amide molecule, which showed improvement in PFS and OS, which was both statistically significant and clinically meaningful. However, in the subgroup analysis, the impact on the high volume patients was not as significantly seen. So when we talk about combination of therapies in order to improve outcome, one of the landmark trials that actually established further therapy escalation was the PEACE-1 trial, which had metastatic hormone-sensitive prostate cancer patients. Patients were de novo metastatic with good performance status, and it was basically a 4-arm trial in which they basically addressed the scope of treatment escalation. Standard of care was ADT alone or ADT plus docetaxel. Basically, this was one of the few studies that addressed the concept of a triplet therapy, that is adding ADT along with chemotherapy along with abiraterone. And what this study showed that a triplet combination, that is adding abiraterone to ADT plus docetaxel, lead to an improved survival outcomes in high volume disease. The low volume, the benefit was not as obvious with a hazard ratio crossing 1. But this gave rise to the proof of concept that escalating the therapy from doublet to triplet benefits certain group of patients, predominantly the high volume and high risk group of patients. And that is where the Arasan study came into picture. It also explored the concept of treatment escalation in patients with metastatic hormone sensitive prostate cancer who were having a good performance status. In these patients received ADT along with chemotherapy, and they were randomized in 1:1 fashion to receive a third molecule in the form of darolutamide 600 milligram BD or a placebo. Primary endpoint was overall survival. Relevant secondary endpoints like time to castrate resistance, time to pain progression, symptomatic skeletal event-free survival, time to subsequent new antineoplastic therapies, safety, so on and so forth. The good part was that almost 87% of the patients received all 6 cycles of docetaxel. So that means large number of patients ended up receiving the standard of care. And it did show significant improvement in overall survival, with the median overall survival not being reached in the Daro arm versus almost 15 months with the placebo group. Hazard ratio of 0.68. And this benefit was seen in all subgroup of patients. Patients with high risk patients also derived benefit from darolutamide with a hazard ratio of 0.7, and low risk also derived benefit. So the confidence interval in the low risk is more towards 1, but still in none of the risk categories, the confidence interval has crossed 1. Important secondary endpoints like time to castrate resistance there was 64% reduction in the time to castrate resistance in the Daro arm, 21% reduction in the risk of time to pain progression in the darolutamide group. The time to first subsequent antineoplastic therapy was delayed by almost 61% in the Daro arm, and the time to first significant skeletal related event was delayed by almost or reduced by almost 30% in the darolutamide arm. So across all important clinically relevant secondary endpoints, we find that adding darolutamide improves these endpoints. In terms of the robust endpoint of overall survival across all subgroup of patients in terms of volume as well as risk, adding darolutamide has shown an improvement in outcome. More important for patient is, patients are more concerned as to how their PSA level is coming down. Clinicians may not attach too much importance to this, but patients are very much concerned that how low or how rapidly their PSA comes down. And in the Arasan's trial, it was shown that not only the number of patients with undetectable PSA was higher with darolutamide, but the time to PSA undetectability was earlier in the darolutamide arm as compared to the placebo arm. And that is what we can see, that time to PSA progression was significantly prolonged in terms of darolutamide versus placebo. And it also showed that patients who achieve an undetectable PSA level at 36 weeks had a better overall survival as compared to those patients in whom the PSA was still detectable at 36 weeks. Though we all know that PSA is not a surrogate or does not replicate in terms of survival benefit, but it gives a psychological confidence or calming effect on the patient that yes, the therapy is working. So, and the outcome in terms of high volume metastatic hormone sensitive, here also, despite the volume of the disease being high, both the number of patients achieving a undetectable PSA level as well as the rapidity of PSA response was much higher with darolutamide as compared to placebo. Time to PSA progression was also delayed with darolutamide as compared to placebo, and overall survival was better darolutamide as compared to placebo. So triplet combination of ADT, docetaxel and darolutamide achieved long periods of low disease progression, and they help to keep the patient in the castrate sensitive phase for a longer time as compared to the placebo group. In low volume, also similar results, both the number of patients and the rapidity of response was higher. So deciding between doublet and triplet, it is basically a matter of appropriate patient selection in terms of the risk of the patient and the volume of the disease that the patient has. We also need to consider whether the patient is going to tolerate chemotherapy or not, the extent of disease like high volume and risk status, the life expectation that we see, what we expect for these patients. Because if you're having a younger patient, it's better to hit hard early so that prostate cancer remains in the sensitive phase for a longer duration of time. And we know that most of the therapies, beyond second line and third line, the efficacy drastically reduces. So especially patients who are at a high risk of progression and who are younger, it is always better to hit them hard earlier in the course of the disease. Thank you very much for the patient listening, and I'll be happy to take any questions at them.
Is there any question?
Yes, I have a question. Actually, we always say that checking PSA does not correlate with survival. So, why is this biochemical discordance given so much importance in our practice? We all check PSA. At the same time, we say that just a bit of fluctuation doesn't matter. So, your take on it. Very nice lecture. So, your take on it.
Thank you, ma'am. Thank you so much, ma'am. Thank you for the question. So basically, one of the reasons why PSA is routinely examined in clinical practice, I feel that it is a surrogate marker of the fact that the treatment is working. That is number one. As we all practice, I don't think we generally change our therapy based on PSA levels alone. Ideally, we should not do, except there are certain criterias, like if your PSA doubling time is very rapid, less than 6 months, I assume, if I remember correctly, or if the PSA density, there are certain criterias. Only in these scenarios we can consider changing therapy, even in the absence of radiological progression. So there are certain situations in which a PSA rise, the magnitude of PSA rise might dictate the change of therapy. In terms of trials, clinical trials, I feel PSA endpoints or PSA related endpoints are taken into consideration mainly as secondary endpoints, even though they do not resemble or they have no direct correlation with survival, is simply because they are achieved earlier. So in a clinical trial setting, that's a more easier endpoint which can be targeted in the terms of a clinical trial which have shorter durations like 2 years or 3 years. So in a disease like prostate, getting an overall survival advantage might take longer time
But if you look into the mechanistic aspect, must be there is some tumor volume which is producing that PSA. Otherwise, where from it is coming? So maybe we need to explore better the role of PSA.
Totally, ma'am. Agreed. But there are number of studies which have shown that despite the scientific sound concept that the PSA would come from the cancerous tissues, the PSA level drop or a rise has not shown a robust correlation with survival outcomes.
So that is the main enigma, I think.
Yeah, absolutely, ma'am.
With this, thank you very much, Nayak sir, madam, and for such a comprehensive and engaging presentation. And we are really grateful for your time and for sharing your valuable experience with us. So with this, I would like to request Madhuchanda ma'am for her kind presentation on bridging clinical gaps in MHSPC, NMCRPC. Or
you have to share my slide and give me just 1 minute.
Yes, sir. Yes, ma'am. Sure.
Can you please share my slide?
Yes, ma'am. I am sharing. Just. Is it visible? My
Yes.
madam, is your camera is working? Okay, ma'am. You can close the camera.
Okay, so shall we begin?
Yes, ma'am.
I've got a bad throat, so sometimes I may cough. So kindly excuse me for that. Good evening, everybody. It's a pleasure listening to these previous lectures. And I thank the organizers for choosing a topic like darolutamide, which is so important nowadays for the treatment of prostate cancer. My topic is bridging clinical gaps in non-metastatic CRPC. Now, we all know that when the CRPC becomes metastatic, the battle starts being very tough, and after some time, we do lose the battle. So, if we can start it earlier, the non metastatic setting, let us look into the role as backed by real world evidence. And we all know real world evidence is the hard evidence as compared to the clinical trials, because it is by not the most premier of institutes, but the institutes where people have great footfall and the standard of care is not that stringent as the clinical trials, but that is how the world goes on as far as oncology is concerned. Next. Nothing to disclose. Next. So I think the unmet need is, where do we place darolutamide in the treatment landscape? And we have an interim analysis of the DAROL trial, which is a prospective observational study. So, as we all know, any prospective observational study has some loopholes, and we must take our spirit in that perspective. Next. So, we all know that hormone sensitive metastatic cancer of the prostate can give rise to a CRPC that is metastatic, or it can give rise to non-metastatic CRPC as well. And we all talked about a lot on the biochemical recurrence as judged by PSA. So 10 to 20% of men who have CRPC will have ultimately CRPC in any diagnosed prostate cancer if we follow them up for 5 years. The majority, around 86% of the patients with the metastatic CRPC actually come from non-metastatic. So those patients with non-metastatic CRPC who have a rising PSA may remain asymptomatic, just now we discussed, and 1/3 of metastatic, non-metastatic CRPC progress to metastatic CRPC within 2 years. So as we said, 5 years follow-up, 10 to 20% develop CRPC, and if they are non-metastatic, 30% around will develop metastatic disease within 2 years. So it's a huge volume of disease that we are talking about. Let us see how we go about it. Next. So patients with shorter PSA doubling time, as we just now discussed, that what is the role of PSA? So PSA doubling time gives a clue that this is a patient who has a greater risk of distant metastasis, and so we must focus or be urgent on treating these patients. So here is a strong predictor for the disease that will progress at a greater speed, that they will develop metastasis, they will have less overall survival. So what is the cutoff of this doubling time? In these studies, less than 10 months has been taken as the cutoff, where the speed of progression will be more. And as we all know, the quality of life and survival will be compromised, and this will have a reflection on the healthcare costs. Next. So, what do we want? Of course, we want survival to improve. Of course, we want a therapy that is tolerable. And of course, we want good quality of life. That means they can continue uninterrupted in what they were doing. So, quality of life has become so important in any patient of prostate cancer as well as in the non-metastatic CRPC. Next. So let us address this unmet need. What more we can do for non-metastatic disease? I think darolutamide as a non-steroidal AR antagonist with a high binding affinity and very selective for the receptor is already known to all of you. Nothing much to discuss on this. So this is the beauty of the drug, a high binding affinity and very selective for inhibiting the AR. Next. So all this has a reflection on the increase in PSA, growth and survival. So darolutamide helps men with non-metastatic CRPC meet their goals of extending life without much impact on their tolerability or the quality of life. So as we find that darolutamide has significantly prolonged survival and has induced robust PS response in patients with non-metastatic CRPC as far as the ADAMIS trial is concerned. You can see that overall survival has very good hazard ratio. PS response is 84%. So it's a favorable drug with good safety, good tolerability that has helped patient meet the therapeutic goals. So living uninterrupted, maintaining quality of life, improving survival, having good tolerability are what has been achieved in the ARAMIS trial. But this is a clinical trial setting. Let us see what happens in the real life, real world experience. Next. So these are all these trials, ARAMIS, Spartan with apalutamide, Prosper with enzalutamide. From all these trials, we get a flavor that the rate of discontinuation due to adverse events are minimum with the darolutamide. That is the most favorable adverse event profile. Next. Now you can see that certain parameters have been compared between ARAMIS, Spartan, and Prosper, like fatigue, falls, fracture, rash, cognitive and memory impairment, very important in elderly. Fracture is also very important, hypertension. In all these, you can find that darolutamide has really scored above both apalutamide and enzalutamide. And as we all have experience with enzalutamide, that cognitive dysfunction is important in these patients. So here is a drug with very good tolerability, adverse event profile, which we can use properly in the proper context. Next. This is a DEER study that demonstrates that patients in the real world setting benefit for darolutamide's strong efficacy and favorable tolerability. See, ARAMIS was a clinical trial, but even in the real world, the DEER study has shown that what was evident in the Aramis reflects even in this real world study. This was in more than 800 patients with non-metastatic CRPC, and it utilized electronic medical record database. Beauty is included 50% of private community urologists. This is a US trial. So private community urologists who are not even in the institution, they also contributed. So that is the real world picture of darolutamide in this scenario. Next. So time to discontinuation or progression to metastatic CRPC was improved in those who received darolutamide. And you can see that graph separation is evident from 6 months, very wide separation. As you can see from the trials, that yet the 95% confidence interval has not been reached with darolutamide. So we find that this is possibly the best bet for us in non-metastatic CRPC to prevent or delay their progression to metastatic disease. Next. Next. The Odenza patient preference study. This was a patient preference study. More patients preferred darolutamide over enzalutamide, 48.5% versus 40%. And all factors influencing preference favored darolutamide. Main thing has been, as we all find with enzalutamide, has been the fatigue. Patient feels so tired and some cognitive dysfunction like unable to concentrate. So all these are very important when patient chooses which drug out of a basket of drugs. And while one is analyzing treatment effect on cognitive dysfunction, darolutamide really showed meaningful benefit in the memory composite score. That means verbal learning, verbal memory, compared to enzalutamide. And we all have real world experience on this. Next. Darolutamide has a low risk of clinically relevant drug-drug interaction, which is so very important in this age group of patients with prostate cancer, because they commonly take calcium channel blockers, some heart failure drugs like cardiac glycosides, proton pump inhibitors for gastritis, analgesics, hypnotics like midazolam, diazepam, antipsychotics, antibiotics, statins, antithrombotics, anticonvulsants. So host of drugs, they have got drug-drug interaction. The least is seen with darolutamide as compared to enza and apalutamide. Next. So darolutamide becomes a new standard of care for patients with non-metastatic disease as well as metastatic hormone-sensitive disease. In patients with metastatic hormone-sensitive disease and non-metastatic CRPC, it is this only drug to reduce the risk of death by as high as 30%, more than 30%. And of course, delaying progression to metastatic CRPC. Darolutamide was designed to be a structurally distinct drug with low penetration of the blood-brain barrier. And this is why it is different from enzalutamide. Of course, favorable tolerability has been confirmed in clinical trials across 3,000 patients. So we all are convinced that in advanced prostate cancer, as well as in those two scenarios which I mentioned, hormone-sensitive metastatic disease and non-metastatic CRPC, robust survival benefit, proven tolerability, maintaining lifestyle uninterrupted, makes this the drug of choice in most of the patients if they can afford. Next. This was the real world study, Darrell prospective observational study in nearly 800 patients. And let us see the interim analysis report. Next. So we report the result of pre-specified IA4, and you can see these are the different timelines. So IA4, nearly 800 patients, and this was July 8th, 2024. This is the cutoff date. Primary outcome, safety, and secondary outcome, of course, and exploratory outcomes, both secondary and exploratory. These were OS, MFS, time to progression to metastatic disease, PSA response, time to undetectable PSA, time to PSA progression, and of course, quality of life. Let us see. Next. Next. So primary endpoint, safety, and secondary endpoints, as I mentioned. So the fourth pre-specified interim analysis. There have been 4 already. This is the 4th one. And the Darrell and Aramis, that is a clinical trial and real life, these comparisons are descriptive in nature. Next. So you can see Darrell and Aramis, they have given in this tabulated form. So age is quite comparable, race, geographical region. ECOG PS, if you look into it, ECOG PS is worse in the Darrell. So all of us who are practicing as prostate cancer specialists, oncologists, we know that lots of patients in this category will come with low performance status. That may be due to their fractures, that may be due to their falls, that may be due to their comorbidities, socioeconomic causes. So it is very practical that we have to give a drug even in this PS, but that is not applicable in the clinical trial of Aramis setting. Next. So as I mentioned, baseline characteristics, Gleason higher in Darrell, PSA entry before the study when we do the baseline, and then doubling time, they have mentioned specially. Less than 6 months, more than 6 months have been their cutoff. So as you can see that in the Darrell IA4 interim analysis, of course, the doubling time is much shorter. So these are the patients with higher Gleason, shorter doubling time of the PSA. So they are actually worse patient. So even with worse patient of high Gleason more than 8, baseline PSA lower, and fewer patients doubling time less than 6 months, Aramis and Darrell must be viewed in that perspective. Next. So safety outcomes. If you look into the right-hand side, Darrell and Aramis, in fact, Darrell has better safety outcomes. If you look into the overview. Okay, more of grade 1 and 2, of course, fatigue, and others rash, fall, hypertension, bone fracture, mental impairment. Grade 3 and 5, very, very less. So meaningful adverse events, much less. Okay, next. Efficacy outcomes. Efficacy means overall survival, progression-free survival, time to metastatic CRPC, median time to PSA progression. That was 38.2 months. Quite long if you see even in real life situation. And PSA response, PSA 50 at any time quite comparable. The important observation, if you look into the right hand side, that the proportion of patients with more than 90% reduction in PSA from baseline was higher in the Darol, that is real life, as compared to the strict clinical trial of Aramis. So this is very, very exciting that in our office practice, beyond the clinical trial setting, we are going to get such, and we have got, not going to get only, we have got, as per these trials, these evidences, very good response of PSA. Next. So this is the efficacy outcome, health-related quality of life. Like say, we want to know mainly about the self-care, how much anxiety, depression, how much hindrance in the usual activities, pain, discomfort. So all these has been very stable for the 3 years they have tabulated here. Next. So what do we conclude? That this interim analysis 4 shows that very low incidence of treatment-related adverse events, no new safety signals in the real-life scenario, secondary outcomes like prostate, PSA-based outcome, survival, progression-free, metastasis-free, all these support the role of darolutamide in real life, in real world. And as we see that health-related quality of life very stable or even improving. So this represents a very varied and clinically diverse population of patients in the real world and supports the established efficacy and safety profiles demonstrated in the ideal clinical trial setting of Aramis. So Darol is ongoing. The last patient visit is anticipated this year in July, and final analysis will come in 2027. So far, this study provides reassurance that darolutamide is very well tolerated, and we all are convinced with that, as well as effective in a broad range of patients with non-metastatic CRPC, with low performance status, with comorbidities. We are really excited to use this drug in many such odd scenarios as well. Next. So it's a mini story. It is a standard of care across non-metastatic CRPC, metastatic hormone-sensitive disease due to robust efficacy and tolerability as assessed in around 3,000 patients in clinical trials and real-world scenario. Patients with non-metastatic CRPC and a short PSA doubling time have a higher risk of distant metastasis, and therefore there is an urgency of treating them better with more important drugs. Many of them are asymptomatic. It is also important we must understand that even asymptomatic will benefit from these. In Aramis, we all are convinced that darolutamide really reduced the risk of death by 30%, more than 30%, as well as delayed metastasis. Darolutamide was designed to have a unique structure of limited penetration to the blood-brain barrier. Discontinuation rates due to AEs with darolutamide really is negligible, highlighting the favorable tolerability. And of course, with darolutamide, patients can extend their survival without affecting their activities of daily living, without interruption in their lifestyles. So if you compare with apalutamide and enzalutamide, all of us would prefer darolutamide in these specific settings. Next. So I think we had a very good exposition of the real world scenario of darolutamide in non-metastatic CRPC, and I thank Bayer for this beautiful research molecule which they have brought for clinical practice. Good evening and thank you all.
Thank you very much, madam, for this very enlightening and insightful presentation. And looking forward to you in near future for such type of wonderful presentations. And with this, I would like to thank Anupam sir, Naresh sir, and Mujunda ma'am for their wonderful presentations. With this,
Thank you. Good night.
good night, ma'am.
Thank you, everyone. Good night.
Should I close the session?
Tech team, can we close now?
Okay, sir.